Hi, this is Cameron Baston. Welcome to PA Cusp's Cardiac Ultrasound Part 2 lecture. We're really going to get into the IVC and the left ventricular ejection fraction interpretation with this talk. So the goals here, remember that Part 1 was all about image acquisition and the challenges that you might have while you're acquiring those images. Part 2 is going to be all about interpreting these images. So we're talking about assessment of LV ejection fraction, particularly LV systolic function, and we're going to talk about volume assessment sort of. There's a lot of stars here because what we're really talking about is IVC assessment with the way that that plays in for interpretation for right atrial pressure. I want you to remember the views of the heart that you had, with the idea being that if you don't acquire high quality images, you can't get high quality information. So make sure that you've practiced getting your images before you start worrying about interpreting those images. A lot of times we'll even say, get the images and then go out of the room and do your interpretation. So here we go, part two. Part two, we're really looking at right atrial pressure in the IVC and the left ventricular ejection fraction. We'll start with right atrial pressure and IVC dynamics. When you're doing this, we talked about acquiring the IVC long axis view, and you look at the hepatic vein draining into the IVC, one of your markers that it's the IVC and not the aorta, and use that as a signpost. Traditionally, you measure the dynamics and diameter of the IVC about 1 centimeter distal from the hepatic vein drainage, or 2 to 3 centimeters from the point where the IVC goes into the right atria. You also can look at the IVC in a transverse view. And when you look at this transverse view, you can see two vessels, both of which are pulsatile. Remember that the pulsatility does not allow you to distinguish the IVC from the aorta, but the location does. You can see that the aorta is directly in front of the spine, whereas the IVC is inside the liver. Also, the IVC is to patient right, screen left in this video. When you're looking at the transverse view of the IVC, you get to see the hepatic veins draining in. And this depends on, as you fan from superior to inferior, what level of the IVC you're looking at. At the beginning here, you can see the hepatic veins draining in, and I think this looks like some sort of demented shadow puppet of a rabbit or a moose, but I spent a lot of time trying to entertain my children under the age of 5. All right, one of the most common fake outs I want you to be aware of is thinking you're looking at the IVC when you're actually looking at the aorta. On the left, you can see an aorta with the spine behind it instead of liver on both sides, and the hepatic vein not draining into it. This same patient, this is the exact same patient, just a few seconds apart, has a completely collapsed IVC. And so remember, if you see only one vessel, it's probably the aorta. If you see two and you're trying to figure out which is which, my favorite way to tell them apart is anatomy. The IVC is to the patient's right, the aorta is to the patient's midline. That said, the other things that are useful are, does the hepatic vein drain in? And two, is there liver on both sides or is there spine deep to the vessel you're looking at? All that said, cardiologists will talk about, does the IVC drain into the right atrium? I've seen this fool people a lot of the time, and you can see why. If you look at that video on the left, it's like, oh, does that drain into the right atria or not? A lot of times, however, my fellows will put the probe on the patient's belly and say, this is all I see. Just farts to be, abdominal gas. And you're thinking to myself, oh, what information can I get out of this? So what I do in those cases is I slide the patient's right. I use either the right upper quadrant or the right flank, and that way I can take the liver and use that as an acoustic window to see through to the IVC, and if you're perfectly aligned at the IVC and simultaneously the aorta. By doing this, I can get the same measurements and the same assessment of IVC dynamics that I would if I was looking at it from the epigastrum. If I want a quantitative measurement for some reason instead of the qualitative, oh, that's big, that's small, that's collapsing, that's not collapsing, I'll use M-mode imaging, and you drop that M-mode marker about 1 centimeter from where the hepatic vein enters the IVC, and you can see how the IVC changes over the course of a respiratory cycle and take very precise measurements. You can do this in both the transverse and the longitudinal view. When you're thinking about interpreting this, though, it's important to remember that you need to know something about the patient. You need to know whether they're on positive pressure ventilation, and the reason for that is if somebody's spontaneously breathing, during inspiration, they create negative intrathoracic pressure. That negative intrathoracic pressure means that there is a pressure gradient from the abdomen, which has not changed to the thorax, where the pressure's dropped, and so blood flows from the abdomen to the thorax. The abdominal IVC collapses. When somebody's on positive pressure ventilation, on the other hand, that means that during inspiration, there's positive pressure in the thorax. That means that blood pools in the abdominal IVC, and the IVC distends. You can think about how that would cause a different physiological process entirely. So instead of just a visual representation of a pressure gradient, you're actually seeing what the capacitance is of that vein. This is kind of interesting because it lets you know whether or not you have any venous space left. You can see that this causes different diagnostic performances and actually represents something else. No matter what, you have to remember that IVC plethora is non-specific. And what I mean by that is it's not just volume overload. It's not just left-sided volume overload in particular. It can be right-sided volume overload independent of left. It can be tamponade. It can be any restrictive cardiomyopathy or constrictive pericarditis. And it can be any source of obstructive shock, be it PE or tension pneumothorax. We also see a couple of IVC thrombi a year. Most importantly for our patients, low volume respiration, such as you'd use in ARDS, can cause smaller pressure changes during the respiratory cycle and the impression of an unchanging IVC regardless of what their right atrial pressure is. In tamponade, a plump, non-changing IVC is actually the most sensitive ultrasound finding. If you look here, you see this IVC and you say, oh, it's big, it's not changing, there's actually a little reversal of flow. Clearly this person's volume overloaded and needs diuretics. But if you look to screen right, you'll say, wait, what's that black stuff around the heart? And that's their pericardial effusion. That's their tamponade physiology occurring in real time. IVC collapse isn't even specific for hypovolemia. There's a lot of things that can cause the IVC to collapse, including somebody most commonly in our patient population who's just very dyspneic. And because they have elevated work of breathing, they have big pressure switch shifts. And so even when they have normal or elevated right atrial pressures, they can cause their IVC to collapse. If somebody has increased intra-abdominal pressure for whatever reason, their IVC will collapse, even regardless of what their right atrial pressure is. When you're trying to estimate right atrial pressure based on the IVC size and dynamics, the American Society of Echocardiography in 2010 let out some recommendations. They basically said, look, if it's small, less than 2.1 centimeters, and collapsing, more than 50% collapse during a normal respiratory cycle, not an aggressive sniff, then that's a right atrial pressure of 3. If it's big, greater than 2.1 centimeters, and doesn't collapse, less than 50% collapse during the normal respiratory cycle, we'll call it 15. And then everything else we'll call it 8. It's important to remember that this is for spontaneously breathing patients, and the thresholds for collapse, or rather distension, for a ventilated patient are going to be totally different. There are not specific recommendations there, and oftentimes the interpretation will just say unable to estimate right atrial pressure as the patient is on positive pressure ventilation. All right, so let's talk about the left ventricle and estimating left ventricular ejection fraction. When you're trying to do this, I'm going to talk mostly about the parasternal views. And when you're looking at the parasternal long axis view, there's 2 ways that I want you to assess LV ejection fraction while you're starting to learn this. Eventually, you're going to have a good enough gestalt for, oh, that's normal, oh, that's mildly impaired, oh, that's severely impaired. And that's as far as I think any of us need to get. We don't need to estimate the LVEF down to 2 decimal places. So here's our parasternal long axis view of the heart. We have a patient with normal systolic left ventricular function on the left and a patient with severely impaired systolic left ventricular ejection fraction on the right. If you look at this, you can see that the mitral valve is highlighted in this green circle. And if you look at that anterior leaflet of the mitral valve, it gets really close to that interventricular septum. Less than a centimeter certainly, almost slapping it. Whereas if you look at the patient on the right, you can see that their anterior leaflet gets nowhere near their interventricular septum. A normal E-point septal separation, that's the thing that we're looking at here, how close that mitral valve leaflet gets to the septum, is less than 0.8 centimeters. And so if you eyeball it and you're like, wow, that's much less than 0.8 centimeters, then it's normal. If it's more than a centimeter, it's like, oh, something's wrong. If you want to get a precise measurement instead of an eyeball, drop M-mode imaging through that anterior leaflet and see how close the valve gets during the E wave, and you can see the E wave on your M-mode tracing. Again, this person with a EPSS of 0.7 has normal LV ejection fraction, whereas this patient whose EPSS measured out at almost 1.7 centimeters has severely impaired LV ejection fraction. Back to the views of the heart. The other way that you're going to train your eye to see what's normal and what's abnormal is by looking at what's called unidimensional fractional shortening. And that's taking the diameter of the LV cavity and saying how much does that change from systole to diastole and back. If you look at this patient on the left, that's decreasing by, I don't know, maybe 50%, 40 or 50%, where normal is anything greater than a third. Patient on the right, it's not changing much at all. Maybe it's changing by 5 or 10%. This is clearly severely impaired. This is a unidimensional measurement that's correlating with a volumetric fractional change, so clearly this is not perfect, but it actually performs pretty well for these kind of categorical processes. When you're looking at the parasternal short axis view, I want you to think about the papillary muscles as being your home level. If you go too high, if you're at the level of the mitral valve, the annulus of the mitral valve holds the circle of the LV open, and you're going to underestimate your LV ejection fraction. If you go down too far towards the apex, at the level of the apex, because the tip of the heart, the apex of the heart, is swinging into your view with longitudinal contraction, you're actually going to overestimate your LV ejection fraction. So here's what that might look like in your parasternal short axis. You've got a normal LV ejection fraction on the left, you've got an impaired on the right. When you look at this, you can do this two ways at the level of the papillary muscles. One, that unidimensional fractional shortening we talked about for your parasternal long axis view. It tends to be a little bit easier in the parasternal short axis view because it's less of a challenge to be perfectly aligned. Because you're looking square to the heart, you can tell whether or not you're getting a good diameter measurement. You can see this person on the left, clearly it's decreasing by more than a third. If you look on the right, you can see this is decreasing by 10% or less, which means that this is an impaired, severely impaired LV ejection fraction. And the other way to do this is what I like to call the finger test, which is you look right in the center of the heart. You get to, and when you're doing this, you get to say, oh, is there regional wall motion abnormalities, or all the walls coming in together? You stick your finger there and you say, hey, this LV cavity looks like it's going to bite my finger. That's a normal LV ejection fraction. Whereas on the right with the red dot, this LV cavity does not look like it's going to bite my finger. That's an abnormal ejection fraction. If you are unconcerned for the safety of your digit, something is wrong with that ejection fraction. Quick reminder, ejection fraction does not mean cardiogenic shock. So if you have somebody who's got a normal ejection fraction, as you can see here, this person has an ejection fraction that approaches 100%, but they were in severe cardiogenic shock because of their massive LV hypertrophy and impaired diastolic function. Their cardiac output was very, very low. So think about that and don't just leap to, oh, their systolic function's impaired, this must be cardiogenic shock, or even worse, their systolic function's normal, this must not be cardiogenic shock. All right, that was part 2 where we went into radial pressure and IVC dynamics, as well as talking about the LV ejection fraction. When you're doing this, make sure you know what your clinical questions are before you scan. Integrate your echo findings with other clinical data, physical exams, and other ultrasound examinations, especially lung ultrasound, and always look for multiple views. We like to say if you see it in one view, that's no view. You need to make sure that you're looking at things at least twice. And when you're looking at the IVC, be careful. It's not as simple as, oh, plump IVC, volume replete, flat IVC, volume down. All right, so with that, go forth, scan, start practicing getting those perfect images so you can get perfect interpretations.